Everyone, it's Dr. Mohib, and in this lecture, we'll be going through glycogen, glycogenesis and glycogenolysis, glycogen regulation, glycogen storage diseases, and at last, some memory drills. So first of all, what is glycogen? As we all know that macros consists of carbs, fats, and proteins. Carbs and fats our body can store, but for proteins, our body cannot store it, and the excess amount of proteins are excreted in our body in the form of urea. The storage form of carbs in our body is glycogen, while the storage form of fats is triacylglycerols or triglycerides. So glycogen is the storage form of our body for carbs. It is made up of repeating units of glucose, or in other words, it is a glucose polymer. If you look at the structure of glycogen, it consists of long chains of glucose. So this is a long chain of glucose. But the interesting thing about glycogen is that it has branches. So this is a branch, this is another branch, and this is another branch. So if you look at the linkages, if you look at this carbon structure, this is first carbon, second, third, fourth, fifth, and sixth. Same for this glucose molecule, 1, 2, 3, 4, 5, and 6. And same for this is carbon number 1, 2, 3, 4, 5, and 6. Now the linear linkages or the linear chains of glycogen are formed by the linkages between one carbon, the carbon number 1 of one glucose molecule, and carbon number 4 of another glucose molecule. It is known as 1,4 glycosidic bonds or glycosidic linkages. While for the branches, it is between the number 1 carbon of one glucose molecule and 6th carbon of another glucose molecule. So it is basically this is 1 and 6. So 1 and 6 is the alpha 1,6 glycosidic bond, or glycosidic linkages is for the branches. So this was all about glycogen storage. Now let's come toward glycogen. Since glycogen is the storage form of carbohydrates in our body, it is stored in two organs, in the skeletal muscle and in hepatocytes. The skeletal muscles, what it does is that it stores for its own use, and when muscles need it, it can undergo glycogenolysis and use it. But the interesting thing for hepatocyte or liver is that it stores it for the use of our body in crisis or in times of need. So whenever our body needs glucose, the glycogen stored in liver will break down and will supply the body with glucose. So hepatocytes store it for the body. Now let's come toward the branches have 1,6 bonds, linear linkages have 1,4 bonds. I hope it is clear now. Now let's come toward glycogenesis and glycogenolysis. If you look at over here, this is the glycolysis or the flow chart of metabolism. Over here we have glucose. So first of all, the hexokinase or glucokinase, depending on the organ, glucose is converted into glucose 6-phosphate. Then glucose 6-phosphate can go on to form pyruvate through glycolysis, or pyruvate can become glucose 6-phosphate through gluconeogenesis. But there is an offshoot from this reaction that glucose 6-phosphate is converted into glucose 1-phosphate, and galactose can also feed into this pathway. Galactose is converted into galactose 1-phosphate, and from there galactose 1-phosphate is converted into glucose 1-phosphate, and this glucose 1-phosphate can be converted into glycogen, and the reverse can also happen. So this was about glycogen. Now let's review it. So over here we have glucose. Glucose is converted into glucose 6-phosphate by hexokinase or glucokinase, and in reverse glucose 6-phosphate is converted into glucose by glucose 6-phosphatase. If you look at over here, glucose 6-phosphatase convert glucose 6-phosphate into glucose, which is which can be released. Now, glucose 6-phosphate, over here we have glycolysis, so this glucose 6-phosphate can be converted into pyruvate, and for gluconeogenesis, the pyruvate can be converted into glucose 6-phosphate. Now, for glycogenesis, glucose 6-phosphate is converted into glucose 1-phosphate, and from there, glucose 1-phosphate is converted into UDP glucose using UTP, uridine triphosphate, and the enzyme that performs it is UDP glucose pyrophosphorylase. This catalyzes this step, and from there, the UDP glucose is converted into glycogen, or in other words, this glucose is added to the chain. So this UDP glucose adds to the chain, then another UDP glucose will be added to the chain, and so on and so forth. So a linear chain is formed, and the enzyme that catalyzes this step is the glycogen synthase. So this was about the linear chain formation of glycogen. But as we know that the glycogen has branching too, so we will have another enzyme known as branching enzyme, the number 4, which will add branches to it. So these branches are added by branching enzyme. So this was all about glycogen synthesis. Now after that we have glycogenolysis, or the breakdown of glycogen. So in same manner as glucose were added to the chain, the glucose are broken off or cut off. So if we cut one glucose molecule from the chain, like over here, the glycogen phosphorylase is the enzyme that breaks the or cuts the glucose from the chain. So what happens? One glucose molecule is cut, then another, same over here. One glucose molecule is chopped off. So this is the same. So one glucose molecule is chopped off, or glucose 1-phosphate is formed, then another, same over here, and they are converted into glucose 1-phosphate, and the enzyme that performs is the glycogen phosphorylase. But there is a difficulty, or the problem is faced by the glycogen phosphorylase, that in branches, when 3 or 4 structures are left, these structures are known as limit dextrins. If this is a side chain, the glycogen phosphorylase can cut this, then another, then another. So when 3 or 4 structures are left like limit dextrins, the glycogen phosphorylase cannot further chop off the glucose, because this dextrin or this structure is stabilized and it cannot perform it. So we will need another enzyme known as debranching enzyme. So what does it do? It chops off the 3 glucose molecules and adds it to the linear chain. So these 3 molecules are from limit dextrins are added to the linear chain, while the one glucose molecule that is left, so the glycogen phosphorylase can again come and chop it off, and then again it can chop the remaining linear chain. So this was about debranching enzyme, and this debranching enzyme is also known as for alpha D gluconotransferase. First, the debranching enzyme has two components, or there are actually two enzymes. The first is for alpha D gluconotransferase. It transfers it into the linear chain, and then another debranching enzyme, the glucose 1,6 glucosidase, chops it off, as in the 7th. So this was all about glycogenolysis. But apart from this, all these happen in cytoplasm. But we have another pathway to the breakdown or glycogenolysis, is that in lysosomes we have another enzyme known as alpha 1,4 glucosidase, which can directly chop off the glucose from the glycogen and form direct glucose. Like it can chop this glucose and form directly glucose, and it is a minor pathway. Lysosomes can also break down glycogen. Now if there is deficiency of enzymes in this pathway, we have diseases of glycogen. So if glucose 6-phosphatase is absent, we will have one Gierke disease. If we have the deficiency of alpha 1,4 glucosidase or the lysosomal enzyme, we will have Pompe disease. Then same, if we have the deficiency of the branching enzyme, we will have Cori disease, the 3 number. If we have for Andersen disease, we have the deficiency of branching enzyme, and for McArdle disease, we have the deficiency of glycogen phosphorylase. especially myophosphorylase. In McArdle disease, we have the deficiency of glycogen phosphorylase, especially of the muscles. So now let's read first aid. Glycogen undergoes glycogenolysis. Glucose 1-phosphate is formed, which is converted into glucose 6-phosphate, which is rapidly metabolized during exercise. As I have mentioned earlier, skeletal muscle stores glycogen only for its own use. The reason is because skeletal muscles lack lacks glucose 6-phosphatase. As I have mentioned in gluconeogenesis, glucose 6-phosphatase, it occurs primarily in liver, and the muscles lack glucose 6-phosphatase. Muscles cannot participate in gluconeogenesis because it lacks glucose 6-phosphatase. Now, for hepatocytes, glycogen is stored and undergo glycogenolysis to maintain blood sugar at appropriate levels. Glycogen phosphorylase liberates glucose 1-phosphate residues of branch glycogen until 4 glucose units remain on a branch. Then, for alpha-D gluconeotransferase debranching enzyme moves 3 of the 4 glucose units from the branch to the linear linkage. It moves into linear linkage, and then alpha-1,6-glucosidase, the another debranching enzyme, cleaves off the last residue, liberating a free glucose. Limit dextrins are 2 to 4 residues remaining on a branch after glycogen phosphorylase has shortened it. So this was all about glycogen. Now let's review glycogen regulation. The glycogen regulation, or in other words, glycogen synthesis or glycogenesis and glycogenolysis. The two enzymes that performs are the glycogen synthesis is performed by the glycogen synthase, and the breakdown of glycogen is performed by the glycogen phosphorylase. So conversion of glucose into glycogen into glucose and glucose into glycogen, and the hormones that regulate these enzymes. So the glycogen synthesis and breakdown are regulated differently in fasting state and fed state. So we have two states, the synthesis and breakdown. Now we have fasting and fed state. In fasting or flight state, and we have fed state of our body. In fed state, we have high insulin, and thus our body goes glycogen synthesis. While in fasting state or in flight or fight mode, our body needs glucose and it breaks down glycogen. Now the breakdown of glycogen is regulated in two steps. This is the first method or first process, and the second is over here. The in first method of glycogen regulation or the glycogen breakdown is via glucagon and epinephrine through beta receptors. So glucagon through glucagon receptors, which are present only in liver, and epinephrine through beta receptors, which are present both in liver and muscle, activates adenyl cyclase. It leads to the conversion of ATP into cyclic AMP. The increased amount of cyclic AMP activates protein kinase A. And what does protein kinase A is that it phosphorylates both glycogen phosphorylase, leads to phosphorylation of, and both glycogen synthase as well as glycogen phosphorylase, both are phosphorylated by protein kinase A. Same goes to glycogen synthesis. For glycogen phosphorylase, it activates glycogen phosphorylase kinase. As the name implies, kinase leads to the kinase are the enzyme that leads to the phosphorylation or adding phosphate group to the enzyme. Same goes for glycogen synthase kinase, glycogen synthase kinase. Protein kinase A activates glycogen synthase, and what does glycogen synthase kinase is that it phosphorylates glycogen synthase. But there is a tricky part, or the thing to remember is that phosphorylated form of glycogen phosphorylase is activated, while the phosphorylated form of glycogen synthase is deactivated. So protein kinase A deactivates it. So what happens as a result is that glycogen phosphorylase is activated and glycogen is broken down into glucose, while the counterpart enzyme, the glycogen synthase, is inhibited. And same goes for the other method. The other method is via epinephrine in liver through alpha-1 receptor. It releases calcium from the endoplasmic reticulum, or the calcium stored in endoplasmic reticulum is released. It binds with calcium cadmolane, which also leads to the phosphorylation of glycogen phosphorylase as well as glycogen synthase, or in other words, it activates the glycogen phosphorylase. Also, the calcium cadmolane complexes are also formed during the muscle contraction. So this is in one pathway, glucagon and epinephrine through cyclic AMP, and the other is through calcium. Whether the cyclic AMP or protein kinase A pathway is activated or the calcium pathway is activated, both leads to the breakdown of glycogen. And for fed state, it is the opposite. We have high levels of insulin in our body. The insulin have both receptors on liver and muscle, and and insulin through its receptor tyrosine kinase dimer receptor, it works opposite to the protein kinase A. It leads to the dephosphorylation. For insulin, I will use the blue color. So what does insulin? It leads to the dephosphorylation, and the dephosphorylation state is opposite to it. The dephosphorylated enzyme or glycogen synthase is activated, while the dephosphorylated state of glycogen phosphorylase is inhibitory. So what we will have that these actions are achieved by activating protein phosphatase or glycogen synthase phosphatase as well as glycogen phosphorylase phosphatase. Phosphatase are the enzyme that removes phosphate from the substance. So glycogen phosphorylase phosphatase will dephosphorylate the glycogen phosphorylase, while the glycogen synthase phosphatase will dephosphorylate the glycogen synthase. The dephosphorylated form of glycogen synthase is the activated form. So in other words, insulin leads to the activation of glycogen synthase and inhibition of glycogen phosphorylase. The easy way to remember is that in fed state, if you look at the names, fed state leads to dephosphorylation. Both the name have ed in it. So fed state or insulin leads to the dephosphorylation, while the fasting leads to the phosphorylation. The phosphorylated in phosphorylated state we have activated glycogen phosphorylase, while in dephosphorylated state we have activated glycogen synthase, or in other words, glucose is converted into glycogen and stored in our body. That was all about glycogen regulation. Now let's switch toward glycogen storage diseases. At least 15 types have been identified, all resulting in abnormal glycogen metabolism and an accumulation of glycogen within cells. Periodic acid Skiff stain identifies glycogen and is useful in identifying these stains. The PAS stain, it converts complex carbohydrates into purple or magenta color, and thus cells having glycogen stored in it will be visualized under microscope using PAS or periodic acid Skiff stain. So this can be helpful in diagnosing glycogen storage diseases. But for USMLE step 1 point of view, the first 5 are important. The first 5 diseases are important, and the mnemonic for this is vice president can't accept money. The vice president can't accept money. So vice for von Gierke or V, which is type 1, then president or P for Pompe disease or type 2, then can't for Cori disease type 3, accept for Andersen for type 4, and money for McArdle type 5. These are 5 type of glycogen storage diseases. All the diseases are the cytoplasmic diseases, or in which cytoplasm is affected, except Pompe disease, which is lysosomal. And another thing, all diseases present in early childhood or infancy, except McArdle disease, which presents in adolescence or adulthood. So this was the general discussion on glycogen storage disease. Now let's dive to each of the respective disease. So the very first disease is von Gierke disease or type 1 disease. The deficient enzyme is glucose 6 phosphatase. If you look at over here, glucose 6 phosphate is converted into glucose by glucose 6 phosphatase. So glucose 6 phosphate cannot be converted into glucose, and we have the disrupted glycogenolysis. But another thing to disrupted glycogenolysis is that if you look at over here, glucose 6 phosphatase, the fourth number, is the last step of gluconeogenesis. So whether the conversion of pyruvate or the odd chain fatty acids, the succinyl through oxaloacetate into to glucose, all the pathways are disrupted of gluconeogenesis because this is the last step of gluconeogenesis. So in von Gierke disease, we have both impaired gluconeogenesis as well as glycogenolysis. So what will be the features or findings of von Gierke disease? The first is severe fasting hypoglycemia. We will have severe hypoglycemia because all the glycogenolysis pathway is disrupted as well as the gluconeogenesis. So these children will have bouts of severe hypoglycemia. In addition to severe hypoglycemia, we can have increased glycogen in liver and kidneys. As we know that glucose 6 phosphatase occurs primarily in liver as well as in kidney and intestinal epithelium. So the glycogen will accumulate in liver and kidneys because the glucose 6 phosphatase is absent. Another key feature is that patients will have high levels of blood lactate. Why is it so? Because the Cori cycle is disrupted in these patients. If you look at the Cori cycle, the glucose in muscles, glucose is converted into pyruvate, pyruvate is converted into lactate, then this lactate goes to the liver where lactate is converted back into pyruvate and pyruvate back into glucose through gluconeogenesis. Since the gluconeogenesis is disrupted, the pyruvate cannot be converted into glucose, and same for, thus we will have high levels of lactate because the pyruvate cannot be converted into glucose. So these patients will have high levels of blood lactate as well as high levels of uric acid. These high levels of lactate will compete with uric acid for excretion in kidneys. Thus, we will have high levels of uric acid and the patient may experience bouts of gout and hepatomegaly and renomegaly. The liver does not regulate blood glucose because gluconeogenesis is disrupted. In addition to these patients also have high levels of TGs or triglycerides. The reason is that if you look at over here, since the gluconeogenesis or glucose 6 phosphate cannot be converted into glucose, so the glucose 6 phosphate will be converted into pyruvate, and the pyruvate will be converted into acetyl CoA, which will be converted into citrate, and the high levels of citrate are the activator of fatty acid synthesis. So we will have increased fatty acids or triacyl glycerides, acyl glycerols or glycerides. So these patients will have high levels of TGs due to high levels of citrate. The treatment is these patients require frequent oral glucose because their body cannot synthesize their own glucose, as well as cornstarch, which is the delayed or slow absorbing glucose. And also one have to avoid fructose and galactose. The reason is that the fructose as well as galactose feed into these pathways, but they cannot be converted into glucose. So if we eat fructose or galactose, they cannot be converted into glucose because the last step is disrupted. So they will fed into these pathways and worsen the situation or condition of the patient. This was all about von Gierke disease. Now the second type is Pompe. Or before going into Pompe, I want you to go to the type 3 or Cori, which is quite related to von Gierke disease. And another mnemonic is ABCD. For Andersen disease, we have the deficiency of branching enzyme, and for Cori disease, we have the deficiency of deep branching enzymes. So in Cori disease, we have the deficiency of deep branching enzymes 1 alpha 1 6 glucosidase and 4 alpha D gluconotransferase. These enzymes are the deep branching enzymes. If you look at over here, in Cori disease, we have the deficiency of debranching enzyme. So what will happen? We will have accumulation of these limit dextrins in the body. So in Cori disease, it is similar to von Gierke disease but milder symptoms. gluconeogenesis is intact, but glycogenolysis is disrupted. Since glycogenolysis is disrupted, the patient will have similar symptoms to von Gierke, but they will be milder and normal blood lactate levels. Why is it so? Because the Cori cycle is normal, and these can lead to cardiomyopathies. Limit dextrin-like structures can accumulate in cytosol, which can lead to hepatomegaly, cirrhosis, and hepatic adenomas. The differences between von Gierke and Cori is that von Gierke have severe hypoglycemia, severe, while Cori have milder. Another thing is that in Gierke disease, the Cori cycle is disrupted, while for Cori disease, the Cori cycle is not disrupted and the patient has normal blood lactate levels. Another thing is that in von Gierke disease, the patient have no muscle involvement because muscles lack glucose 6 phosphatase. But for Cori disease, the patient have muscle involvement. So the patient may experience hypotonia, cramps, etc. because the glycogen stored in muscle cannot be broken down due to the deficiency of debranching enzyme. Now, then we have Pompe disease or the type 2 disease. It is due to the lysosomal degradation or lysosomal 1,4-glucosidase or acid maltase deficiency. So what happens in Pompe disease is that glycogen accumulate within the lysosomes, and the buildup of glycogen leads to the breakdown and disruption of tissues. So the mnemonic for Pompe disease is Pompe trashes the pump. The P are in first letter and fourth for the enzyme 1,4-glucosidase. The enzyme has alpha 1,4-glucosidase for P. P both in pump as well as Pompe, it is fourth letter, and the organs involved are heart, liver, and muscles. The symptoms are cardiomyopathy, hypotonia, exercise intolerance, enlarged muscles, especially enlarged tongue, and systemic findings leading to early death. The buzzwords for Pompe disease are cardiomyopathy, the pump failure. In Pompe disease, the concerning symptom is pump failure as well as enlarged tongue, which is a pretty unique feature for child or infants. And for von Gierke disease, the buzzwords are severe fasting hypoglycemia and elevated blood lactate levels. For Cori disease, limit dextrin-like structures are the buzzwords. Then we have Andersen disease or type 4 disease. In Andersen disease, we have the deficiency of branching enzyme. The glycogens, these linear chains are formed, but the branch chains cannot be formed. So the fourth number in branching enzyme, we have Andersen disease. What happens in Andersen disease is that we have accumulation of linear chains within the organs of our body. And these linear chains are different from the branch chains or normal glycogen stored in the bodies. What happens in Andersen disease is that the immune system of our body thinks of this glycogen, the linear chain or unusual glycogen, as a foreign body and attacks it. So this leads to widespread inflammation and immune responses in our body. It mostly presents with hepatosplenomegaly and failure to thrive in early infancy. Often findings include infantile cirrhosis due to liver damage and liver inflammation, muscular weakness, hypotonia, cardiomyopathy, and early childhood death. Hypoglycemia occurs late in the disease, and this hypoglycemia is due to the liver damage, not due to the disruption of gluconeogenesis or gluconeogenesis. And at last, we have McArdle disease or type 5 glycogen storage disease. In McArdle disease, or type 5, we have the deficiency of glycogen phosphorylase, especially the myophosphorylase or the phosphorylase of the muscles. So what happens is that skeletal muscle glycogen phosphorylase known as myophosphorylase is deficient. So the blood glucose levels are typically unaffected because the gluconeogenesis or the blood glucose levels are maintained by the liver, and the liver phosphorylase, glycogen phosphorylase, is intact. So it only affects the muscles. Increased glycogen in muscles, but muscles cannot break it down. So this will lead to painful muscle cramps in exercise, as well as if these patients start to exercise, this will lead to rhabdomyolysis or breakdown of muscle tissue. This will lead to the spilling of myoglobin into blood and urine, turning the urine into red color, as well as the patient will have high levels of creatine kinase due to the spilling of creatine kinase of the muscles, and the The patients may also experience arrhythmias from electrolyte abnormalities, especially the potassium spilled from the muscle tissues with strenuous exercise. These patients experience second wind phenomena noted during exercise due to increased muscular blood flow. And this disease is characterized by a flat venous lactate curve with a normal rise in ammonia levels during exercise. So the key features of McArdle disease are second wind phenomena and flat venous lactate curve. The McArdle disease is diagnosed. The patient, this is the patient arm, this is biceps or arm, this is forearm and hand. The cuff is rotated around the arm and the patient is told a hand grip is given to patient and the patient is given an instruction to perform hand grips alternatively, or the patient is asked to perform contraction while the arm is while the rotator cuff is inflated, or in other words the forearm muscles are activated in absence of oxygen. So in absence of oxygen, the forearm muscles exercise and blood is taken at different intervals. So at start, the cuff is rotated so that blood flow is halted. Then the patient is asked to perform exercise and blood is taken from the veins at different instants. At first at 0 minute, then at 2, 4, 6, 8 at different instances, the blood is taken from the forearm. So what happens in normal case is that in absence of oxygen, the glycogen stored in the forearm muscles will provide energy, and what will happen is that the glycogen will be broken down into pyruvate, and the pyruvate will be converted into lactate. So we will have normal rise in lactate. So if we let me clear it. So with time, if we 0, 2, 4, 6, 8, so if we plot it against time, so the lactate levels will start to rise in normal patients, but for McArdle patients, since they cannot break down the glycogen, so the blood lactate levels throughout this period will remain same. And another thing is that these patients experience rise in ammonia levels, but for normal patients the ammonia levels will be normal throughout this period. So the ammonia levels will be normal for normal individuals, but for McArdle patients there will be a rise in ammonia levels. Why is it so? It is actually, or this is due to the fact that since these patients or these individuals cannot break down the glycogen, and in absence of oxygen and strenuous exercise, these patients require ATP. So the ATP comes from the breakdown of protein or the muscle itself, and this muscle breakdown leads to the release of ammonia, raising the ammonia levels in the venous blood. So this was about the flat venous lactate curve with normal rise in ammonia level. And another thing is second wind phenomena. What happens with these patients is that when they go for strenuous exercise, in strenuous exercise, there is rapid depletion of ATP in the muscles, the stored ATP. So in normal individuals, these ATPs are replenished by the glycogen stored in the muscles of the body. Since these patients cannot replenish the ATP through glycogen, these patients experience painful muscle cramps because actin and myosin attach in during contraction, and for their detachment ATP is required. Since these patients have no ATP, they experience painful muscle cramps due to the actin myosin attachment. But if they still carry on or go through this phase, then the second line of nutrients come for rescue. The second line of nutrients are the fatty acids breakdown, and as well as glucose from the liver comes to rescue. The blood vessels dilate and the fatty acids and glucose come and provide this ATP. So after this painful, if they somehow manage to go through this painful crisis or this period, then after that they can again replenish the ATP through the second line of nutrients, and thus they can prevent or carry on with the exercise. So this was about the second wind phenomena. This was all about glycogen storage diseases. Now, if anyone is interested in visual learning, so I have provided this chart of glycogen storage diseases, in which the glycogen storage diseases are shown by this accumulation of boxes of glycogen, and the liver and muscles show that these affects the liver and muscles. Over here we have the vice president saying, I can't accept money. The type 1 is von Gierke's corner. If you look at this baby, this has doll-like faces. A fat kid with hepatomegaly and renomegaly. Over here we have a glucometer showing severe fasting or very low blood glucose level, and over here these tubes showing high levels of lactate, TGs and uric acid for gout, and this is for treatment. This patient is provided with cornstarch and glucose. So this is one Gierke disease. Then we have Pompe or the Pompe's pumping system or type 2 trashing and crashing. The heart or pump is crashed, showing 1-4 showing the enzyme deficiency, Pompe trashing or the crashing of the heart, as well as the muscles, the flaccid cardiomyopathy, hypotonia, and this large tongue, the characteristic feature of this, and the child showing or the angel for the early childhood death due to the pump failure. Then we have Cori's limit station. If you look at our hair, normal lactate to differentiate between one Gierke's, mildly low for blood glucose differentiation, and these structures for limit dextrins, and the liver is happy because gluconeogenesis is intact. Then we have type 4 or Andersen's branching disease. The tree shows the branching. If you look at the liver, this patient have cirrhosis, as well as muscles are crying because muscles are involved due to the inflammatory response, and the at last the McArdle's gene for M for this muscular man or McArdle man having painful muscular cramps. The patient is making faces for painful muscular cramps. Second wind for second wind phenomena, the increased blood flow for second wind phenomena, the patient is running, and the graph for normal venous lactate and increased ammonia. And over here we have the same mnemonic. And at last, some memory drills. Number 1. Which glycogen storage disease is associated with limit dextrin accumulation? Pompe disease, Cori disease, Andersen disease, or McArdle disease? And the correct option is Cori disease. Cori disease for the limit dextrin-like structures. Then, glycogen phosphorylase stops degrading a branch when how much residues remain, or limit dextrins. So, limit dextrins consist of 1, 2, 4, or 6 residues, and the correct option is 4. And at last, which glycogen storage disease is most associated with elevated uric acid and gout? Is it Cori, Pompe, Andersen, or von Gierke? And the correct option is von Gierke disease due to increased lactate, which compete with uric acid for excretion. This was all about glycogen and glycogen storage diseases. Thank you.